Hi, I'm Dr. Joel Mortensen. Thank you all for inviting us today. Today, together with Dr. Julia Malkowski, we'll be discussing the clinical value of the GI360 test. We'll be looking at some exciting research, some new reporting updates, and then Dr. Malkowski will be talking about some important cases in the use of this new data. So basically, I'll share some technical aspects, and then Dr. Malkowski will look at some cases with you. So we've learned a lot about the microbiome in the last several years. In fact, there's been a tremendous growth in studies of microbiome of the gastrointestinal tract, of the skin and soft tissue, as well as respiratory tracts. So we have lots and lots of new research data. And to be honest, we've known about normal flora for a number of years, but the complexity and the diversity of that microbiome was basically beyond our technical capacity to study. But with these new studies, clinical interest has also grown. And this new clinical interest to bridge the gap into the research world has started us at Doctors Data on a new journey. So here are some of the roles of the microbiome in health, and then potentially some of the diseases associated with the microbiome. So on the left-hand side, I've listed just some interesting functions that have been impacted by the microbiome. So there's host physiology with adaptive immunity, innate immunity, bone density and vascularization. Microbiome is involved in biosynthesis, so neurotransmitters, steroid hormones, and vitamins. Microbiome is also involved in metabolism. But also important, microbiome is probably involved in some diseases. And although this is not, again, a comprehensive list, and the research in the end may not support the microbiome involvement in all of these disease states, there's some important and interesting discussions here having to do with allergies and allergy protection, heart disease, cancer, diabetes, immune-mediated inflammatory diseases, liver diseases, neurodevelopment, and a variety of others. So again, what's needed from us? Well, what we needed was a bridge between research, diagnostic testing, and treatment. So we're working on a standardized and routine tool to profile the microbiome and link this to clinically actionable results. We want to identify microbiome profiles that will aid in the diagnosis and to guide selection and therapy. And we want to identify risk profiles, microbiome profiles, that may be associated with major diseases such as diabetes, obesity, and inflammatory bowel disease. So to accomplish that, Doctors Data partnered with Genetic Analysis, GA, which is a company based in Norway, but we partnered with them to bring a CE-marked assay to the US. And this dysbiotic test is intended to be used to test gut microbiome DNA analysis with a standardized and validated test that is highly reproducible. First, let's start in the laboratory. In this graph, it's based on six patient samples run in triplicate with 3 different lots of kits and repeated 3 times. So we ran through this a whole lot of times. The idea is to look at the clustering. So the repeatability measures within run variability, and reproducibility takes in all variation. So you notice that each of these 6 different ones are slightly varied from run to run, but cluster very highly, giving us a reproducibility and repeatability that have very, very low CVs, or coefficients of variance. Clinically, we also needed to look at validations. And the dysbiosis test uses a normal biotic reference population with more than 500 samples representing individuals that were carefully screened to follow into a non-diseased, healthy, normal biotic state to start as our reference. And then, can the test differentiate important populations of patients and identify key clinical characteristics? So much like A1C, for example, differentiates populations at potential risk, not necessarily a discrete measured number, but again, rather the ability to sort and separate. So this dysbiotic test was originally based on the differentiation of normal biotic and dysbiotic patients. In this example, IBD represented 135 patients, IBS 236 patients, and then 297 healthy patients. And what we can see, although it's not 100%, it clearly separates dysbiotic and normal biotic in the inflammatory bowel disease patient population, as well as in the irritable bowel syndrome population, and correctly sorted healthy patients into the normal biotic population. And this was some of the original work that went into proving that we had a test that could differentiate normal biotic patients and dysbiotic patients. There's more than now almost 50 peer-reviewed articles with clinical data on more than 5,000 patients and 50 clinical trials that support the utility of the ability to separate these populations. So in brief, this test is a PCR-based assay that uses 54 sets of primers for specific groups of bacteria and bacterial species that were selected to differentiate patients with a normal microbiome, normal biotic, versus dysbiotic microbiome, specifically designed for the gastrointestinal tract. So how did doctors' data go about bridging this diagnostic gap from research to clinical application? So we did that by combining key elements. The microbiome that I was just describing for you, the detection of known pathogens using polymerase chain reaction, along with standard conventional methods and additional testing of significant host factors. So we're using a standardized, straightforward tool to profile the microbiome and to link this to clinically actionable results. And we think that we can identify profiles that aid in the diagnosis and guide of selection of treatment, as well as identifying risk profiles for some major diseases. So what does this look like? Doctors' data has incorporated the microbiome test that I presented earlier, along with key PCR and conventional tests. This image is the beginning of the results page of the GI360 test. First, the graphic at the top summarizes the abundance or the amount of key bacteria and the diversity, the number of different groups of 6 key bacteria phyla listed here. The green zone represents the normal biotic range in the center here. And if a patient has a lower amount, the white center of this graph is pulled in, as you can see here with Firmicutes. If they're higher, the white center is pulled out, as you can see with the Bacteroides group. In addition, there's 2 new indicators, dysbiosis and diversity. So again, based on the bacterial populations, the dysbiosis score, in this case, represents a microbiome profile that differs from our normal biotic population. A diversity score of 3 is the expected, and in this case, our diversity is actually increased compared to our normal biotic group. So for a little more detail, the markers are based on a verification study of just over 1,000 subjects, compared to an IBS and IBD population. In addition, there was a follow-up validation study of 638 healthy subjects where the DI scores were not excluded, and again, compared to an IBS and IBD population. So we have nice, solid data that looks at both the dysbiosis score, meaning variation compared to normal, as well as the diversity of the populations. Finally, we have 5 new functional markers, and we're really excited by the ability to look at these groups of key organisms and then looking at imbalance. So our first group is butyrate-producing bacteria. These 3 groups were shown to be highly correlated with butyrate production. And if at least 2 of the butyrate producers are below the healthy range, that shows to be out of balance. our gut mucosa protective bacteria, our gut intestinal health markers, gut barrier protective versus opportunistic bacteria, and pro-inflammatory bacteria are our additional functional markers. And so we're providing here the bacteria, the profile criteria for imbalance. And then we also, as part of this test result, give you a lot of markers that discuss the various descriptions contained within them. So the summary of those results are shown here as either expected or imbalanced. After the summary information, individual species and groups of organisms can individually be analyzed and compared to the normal biotic patient population. So let's look at this just a bit. For example, the actinobacteria, the groups that are contained within that phyla, and then our center is within reference range, low and lower, high and higher are compared. So we can go through each of these individual groups and begin to tease out which of them may be abnormal if our diversity score or our dysbiosis score doesn't give us the level of detail. So to look even closer, then you can see here very specific organisms within the group, the normal range, and those that fell below. This is then just a summary. There's much too much detail to go into, but this is just all of the primer sets, all of the data on all the bacteria, all the way from the actinobacteria through the proteobacteria, Firmicutes, and beyond. So microbiome is important, but there's more data to be derived and more information that we need to get a true picture. So I also wanted to touch for just a moment on the role of PCR versus culture in detection and analysis of stool pathogens. So there's a combining of key elements, PCR and culture for pathogens and flora, in addition to the strong microbiome test. So both types of tests have an important role. Nucleic acid amplification, such as PCR, have added to our ability to detect individual pathogens. But PCR has some limitations. We have to be very clear on the targets selected. In addition, we use traditional culture, which can also provide a significant amount of data through the use of MALDI-TOF for the identification of flora and pathogens. So PCR, the development of an FDA-cleared, validated platform, is key to the reliable detection of stool pathogens. And this is well worked out and has been for a number of years. Next-gen sequencing and a variety of other methods may be employed, but the clearest, focused way to do that is with an FDA-cleared platform for pathogens. This standardization leads to high sensitivity and reproducibility. As I mentioned, the results may be limited to specific primer sets, and in fact, that's probably a good use of the methodology, is to clearly focus. It's a very effective test for a variety of pathogenic bacteria, virus, and parasites. And again, this is just an example where we're looking at particular important viral pathogens, bacterial pathogens, and parasites. And in this case, the results are simply positive or negative for their detection. So microbiome data is combined with this multiplexed PCR. And again, we can see there's a large number here. These are not quantitative tests. These are qualitative. Is Campylobacter present? Is adenovirus present? Is Shigella present? The relative quantity is not a useful indicator. Present or absence is associated with disease. And what about the use of stool cultures? Stool culture is still the gold standard for the microbiology of pathogenic bacteria. This allows us to isolate organisms for standardized antimicrobial susceptibility testing. And that antimicrobial susceptibility testing may be prescriptive agents or maybe biological agents or botanical agents. So it allows us to isolate and focus that testing on organisms that we think may be causing either an imbalance or a true infection. Culture also allows to identify unique organisms such as Archobacter and unusual yeasts that may be present, perhaps even in smaller numbers, but may be important additional organisms. And we utilize MALDI-TOF, which is mass spec time of flight, which has a library of over 1,500 genera and species of bacteria and fungi to allow us to do some of that specialized and focused work. And finally, I also wanted to touch on the fact that we have some very interesting ongoing innovations in research. So we're not just presenting a test, but we're continuing to look at how to refine and utilize that test better. So 2 exciting studies that are ongoing. We realized that the DI score, the GA test, was not designed for pediatric patients. And so we're working diligently for the development of accurate normal biotic reference ranges for pediatric patients based on both retrospective and prospective studies. We also have learned that in the very, very young, in the infant range, it may be a completely different world in the microbiome. In fact, we know that from research studies. And how to adapt our present assay for looking at that very young population is also terribly interesting work that we hope to make some really good progress with. The other one that I wanted to really highlight is the process of connecting the microbiome to biochemical findings. So we think that correlating gastrointestinal inflammation or markers for inflammation, such as lysozyme and calprotectin, to changes in the GI bacterial composition, especially in patients with suspected IBD and IBS, may have a very strong correlation. So presently, we have a cohort of more than 7,000 patients in the age range of 16 to 90, including more than 2,000 suspected IBS and 125 IBD cases, where we're going to be looking at proteobacteria along with Escherichia to correlate with these inflammatory markers. And we think that, again, calprotectin, lactoferrin, lysozyme, and perhaps some other markers may give us a strong indication of the inflammatory processes going on as it's balanced against the microbiome. Well, that's my quick update from the laboratory. Now I'd like to turn this over to Dr. Malkowski so that she can talk about perhaps more important ideas, which is what to do with this information when we're treating our patients. Thank you very much.
Thank you so much, Joel, for that excellent information. And now we will continue on with this information and we will get the chance to look at some exciting cases. And again, I'm Dr. Malkowski, Scientific Support Specialist at Doctors Data. Let's begin. Here we have some cases here, and these are some new cases in the field. So our first case is a 23-year-old female, and this woman has suffered with GI complaints of unknown origin. And this is probably a common case in your office in that the patient just really has a significant history of GI complaints without a diagnosis, and they're just kind of living with this, right? So this patient presents with digestive complaints, so gas and bloating after eating, sometimes constipation, sometimes loose watery stools. And this is one of the cases where you would really be surprised, but not too surprised that, people are really just living with GI issues on the daily basis. And so we're really at a great place here to help patients with the GI360. So let's take a look and see what her result reveals. So for this woman, we do have her GI360 result here, and we're going to go through the report and I'll explain the key components along the way. The first piece of information we have here is the web, and the web is a visual representation of abundance and diversity by phyla. And this is a great snapshot into your patient's microbiome. Here we have your patient's result, which is that white web superimposed on the normobatic reference range, which is that green hexagon. And as we can see here, the white web is actually not making a hexagon, and we can see that green normobatic reference range peeking out below it. This patient's result is almost a rhomboid. And this is an excellent teaching tool for your patient. You know, this is a great way to say, yeah, I can see here that you have had digestive issues, because we can see here there is an issue with abundance and diversity. And as we know, abundance and diversity is really the keystone to microbiome health, which does influence systemic physiology as well. The next piece of information we have with the GI360, and each piece of information with the microbiome will become more and more detailed. So the first piece of information we have is the web organized by phyla, and then we have the diversity scores and the dysbiosis index and the diversity score. So the first score is going to be that dysbiosis index. Scores go from 1 to 5. 1 and 2 are healthy normobiotic guts, and then 3, 4, and 5 are dysbiotic guts. And for dysbiosis, we do not want dysbiosis. So the lower the score, the healthier the gut. And diversity is the inverse. We want diversity. We want a rich, diverse microbiome. So scores go from 1 to 5, although 1 and 2 are unhealthy scores. 3 is a moderate score, and then 4 and 5 are those healthy diversity scores. So we can see here the patient has significant dysbiosis with a score of 5, and the patient has less diverse microbiome, so significantly less diverse microbiome with that score of 2. All right, so let's see further information here. All right. So we're going to continue on, and this is all on the first page of the GI360, and the key components are here. Again, we have that dysbiosis index score of 5, that diversity score of 2. So what exactly is happening? The great thing about GI360 is that that key findings page is organized into functional guilds, and we have 5 functional guilds here. The first functional guild is the butyrate producing bacteria. And these bacteria are so important within the human colon because butyrate is really a building block, a building chain for colonic health and for the rest of the microbiome. We also have the second guild, which is the gut barrier protective bacteria. And that's really important because that gut barrier is so healthy with regards to human colonic health. And then the third guild is going to be the gut intestinal health marker. And obviously gut intestinal health is very important with regards to colonic health, but then systemic physiology as well. The fourth guild is going to be those inflammatory bacteria, because as we know, inflammation is such a crucial component of health, especially with regards to the colon. And then the fifth guild, the functional guild, is going to be a balance. And this is a balance between the gut barrier protective bacteria and the opportunistic bacteria. And as we know, balance is so key to human health, and we can see this here within the microbiome here. And so the great thing about the GI360 is there's a wealth of information, and it has been computed into these functional guilds. So you do have clinically actionable results right here on this first page. So going back to our patient, the dysbiosis index score is 5. So we do know there's significant dysbiosis. The diversity score is 2. So we know there's lacking of diversity within the human colon. We also know that the butyrate producing bacteria are low, and we do want to support these bacteria. And as we know, really important to the fiber feeding approach is actually going to be one of the best ways to produce, to support these butyrate producing bacteria and increase that butyrate. And the inflammatory bacteria are also influence for this patient as well. They're too high, and that is playing a role with regards to that dysbiosis index score. So we want to think for the patient about inflammation. We want to think here diet, maybe the patient's on standard American diet, which we do see. Maybe there's excess fats, excess proteins, things like that. And then same thing with the butyrate. We want to think about a dietary approach. We want to think about adding fiber, soluble fiber, red beans, red kidney beans, inulin, chicory, Jerusalem artichoke, things like that. And then you could also take your own therapeutic approach. So you could add the prebiotics. And then for inflammatory bacteria, you could also use your own approach to decrease inflammation in the colon with specific supplements, turmeric, fish oils, things like that. So it's a case-by-case approach as well here, and you have a lot of options, but all the information is really put together right here in the key findings with regards to these functional guilds, right? Then we will continue on with the next column. These are additional findings from the report. So here on the first page, you will have reported any other findings of the patient's results. So if there are any cultured bacteria, if there are any pathogens, any parasites, viruses, inflammatory markers like calprotectin, lactoferrin, that would all be right here on the first page in the second column. And these are going to be treated essentially individually. So for this patient's result here, we do see the butyrate is low and the percentage butyrate is low. So there's two markers for butyrate. The percent butyrate is with regards to the other short-chain fatty acids, such as propionate, valerate, et cetera, because we know that short-chain fatty acid balance is important within the human colon. So in this result, we can see the percentage of butyrate compared to the others is low. And then frankly, butyrate itself is low. So again, we are going to take that fiber feeding approach to support the butyrate producing bacteria and increase the butyrate. So all of this information actually does go together. The next piece of information we see for this patient is beta glucuronidase is low. And we hear so much about elevated beta glucuronidase. But we do know that low beta glucuronidase might be associated with low diversity. So let's address the patient's diversity based on the findings that we've already discussed and retest this patient, and we can take a look and monitor that level of beta glucuronidase. Additional considerations for this patient, recall the patient's chief complaint is just just non-specific GI disturbances. And we do know with the dysbiosis index score of 5, that can be causing that. Low diversity could be causing that, low butyrate as well. So we do have key findings here. But then we also note the patient has a cultured Klebsiella and a cultured Candida. So the Klebsiella is a common dysbiotic bacteria within the human colon, and then the Candida albicans is a common yeast within the human colon. And these can be addressed as well. So in this case, it's actually a great idea that the functional medicine provider provided this test actually for this patient, because they no longer have to suffer with the GI complaints every single day. There are some actionable results here. Here we're going to take a look deeper into specific components of the test. This is the culture page of the GI360. So for this report, this is the culture, and this is an individualized page for your patient. So no two page will ever be the same, most likely. The first part of the report is going to be the pathogenic bacteria. Now, these are the pathogens, Aeromonas through Yersinia. These will always be cultured, the sample will always be put in specific growth medium to elicit the culture of these bacteria if they're found. That would be reported. But then the rest of the information is going to be dynamic for your patient. So imbalanced bacteria, there could be anything here from 0 to maybe a dozen, because there's a variety of imbalanced bacteria, commensal bacteria that exist within the human GI tract, and they don't exert significant physiologic consequences, but we note them here, okay? And so we don't necessarily treat those. The next section, the dysbiotic bacteria, those bacteria we will treat, okay? And so for this patient, she has a 4+ Klebsiella. That's a good amount of Klebsiella in the colon, and this can be contributing to her presentation. So you do want to treat that. Candida is actually of note here at level of 1+. And it is common to have yeast growing within the human colon at 1+. It is considered within normal limits, and that's going to be a clinical decision based on the patient's presentation history if you want to go ahead and treat that. Here we see what's called the stool chemistries portion of the report. And on this page, there is a wealth of information. Recall, the patient was presenting with digestive complaints after eating, like gas, bloating, etc. Well, here we see elastase is actually robust and healthy at 500. The fat stain is none, and the carbohydrates are negative. So these are healthy. So we know that's not the crux of the patient's consideration. It is that dysbiosis index score of 5, that low diversity as well, and then also the findings of the Klebsiella as well. So we do note as well here the inflammatory markers, lactoferrin, lysozyme, and calprotectin are all within range. So this is great information to exclude those, the pathogenesis of IBS, IBD. And then of note here, IgA is right within range at 80, so that's healthy. We don't want IgA to be too high. We don't want IgA to be too low. Remember, it is about balance. Okay, so that's good. And like we discussed, the butyrate here within the short chain fatty acid profile, butyrate percentage is low, and then butyrate value is low. So that butyrate is pretty low. And again, the fiber feeding approach, and it goes back to the soluble fiber, the prebiotics, we want to support the patient's butyrate. The last consideration here is the intestinal health markers. And within this, we're looking at pH, beta-glucuronidase, and occult blood. The pH here is within range, so that's great. Occult blood is negative, and that's healthy. Just of note here, occult blood is upper GI. That is a different marker than the RBCs that we do identify as well. So the beta-glucuronidase, like we discussed previously, is lower, and that is associated with the low diversity score. So it would be really recommended to treat this patient and retest. With regards to that, regarding timeline, the consideration would be if you're going to do an antimicrobial approach, you want to wait until that's done, and then maybe you would rebuild with probiotics, and then just wait 2 weeks after the probiotics or the antimicrobials to retest. Generally speaking, that's going to be somewhere around that 12-week mark, okay? On to our second case. So our second case is a 26-year-old female. Now, this patient presents it with a history of GI disturbances of unknown origin as well, but there is a diagnosis of intestinal permeability. So this patient is seeking care to kind of understand a little bit more about that. Look at this with GI360. What can it tell us about this? Again, the first piece of information we have is the web, and the web is organized by phyla. Now, of note here, for this patient, we have lower actinobacterium. A clinical pearl is that phylum actinobacteria, they do enjoy vegetables. So I would think about the diet for this patient. We have a slightly higher proteobacteria. We have lower vermimicroba. So I'm kind of thinking about mucosal barrier integrity here, inflammation, and then we have higher bacteroidetes, higher firmicutes. That web is not making a hexagon, but it looks improved compared to the last one, right? So it looks closer to a hexagon, but it looks almost like a squished hexagon, just as a visual there. So we're thinking moderate. And then we do see the dysbiosis index score of 3. So 3 again is moderate dysbiosis. It's neither significantly dysbiotic nor healthy. Same thing with diversity. So the diversity score is 3. So neither abundance of diversity or decreased diversity. So in this case, we're going to need a little bit more information. So let's continue on the first page of GI360, the key findings, to see the details here. All right. So within the key findings, we are going to look at the functional guilds again. Recall there are 5 functional guilds. The first consideration is that butyrate-producing bacteria. And like Dr. Mortensen so eloquently explained, we do have these specific bacteria that are considered here. The fecal bacterium Prenitzii, the U bacterium hali, they're key bacteria within the colon that are contributing to the butyrate production, okay? And so when those bacteria are decreased, that's when we see this functional guild is alerted to be imbalanced. And you have that information right on the first page here. Additionally, we do see the gut barrier protective bacteria are low, and that does make sense with the consideration of intestinal permeability, because one of the pathogenesis of intestinal permeability is when there's dysbiosis present, and specifically the gut barrier protective bacteria, when they are influenced, then we have decreasing mucosal barrier integrity, which can lead to intestinal permeability. So we do see that pathogenesis, and that's what's contributing here. And it's good that we have this information for this patient so we can go ahead and support the gut barrier as well. The gut intestinal health markers, those bacteria are influenced as well. The pro-inflammatory bacteria are okay, but then we do have a misbalance here between the gut barrier protective and opportunistic bacteria. So we really want to address all of these things congruently to help this patient. Additional findings for the patient that has presented with GI disturbances is we can see here the second column. We do see the C. difficile toxin A and B has been detected. There are carbohydrates. There's low secretory IgA, so low immune function, and then the beta-glucuronidase is high. So we're going to talk about these. Recall that with the beta-glucuronidase being high, we saw right away the patient does have lower actinobacteria. Remember, they like vegetables. So we're already thinking about adding vegetables, adding fiber, things like that. So that should help with this, addressing the dysbiosis, addressing the diversity, that should help with that as well. Okay. So for this patient, we're going to take a look at the Firmicutes phylum because we do have functional guilds involved here. And so we just want to take a greater look at this. Recall, the butyrate producing bacteria are influenced. And we can see here that the Eubacterium hali, which is a keystone butyrate bacterium, the Fecalibacterium prognathia as well, these are both low. And so in this case, we do want to approach this with the fiber feeding approach. So we want to really support this patient 8 to 15 grams per day of fiber. Most people are nowhere near that. So we really do want to help this patient with that, okay? And then at the bottom of the page, third from the bottom, I do note the Ruminococcus navis is too high. That species is associated with mucosal barrier integrity. So we already know that that is a factor for this patient. So we do want to balance out these species, and we do want to support this to support mucosal barrier integrity to help with the intestinal permeability. And here we have the GI pathogens portion of the GI360. So this is the page in which we are identifying the most common causes of acute gastroenteritis. And here we're looking for viruses, pathogenic bacteria, and parasites. So for this patient, we do have a positive C. difficile toxin A and B. This patient, we do want to consider their history, their presentation, have they, was this hospital acquired, those types of things. Is this a recurring infection? Or with the PCR, this is very sensitive and specific. So this could actually show asymptomatic carrier status, or it can show resolved infection. And so we do need to do a little bit of detective work and work with our patients there, what's going to be the next best step. And here we have the stool chemistries page of the GI360. There's a wealth of information on this page. The first piece of information we have is the digestion absorption. And again, for this patient, we see elastase looks really good at 500, fat stains are none, but take a note of these carbohydrates. We do have carbohydrates positive here. Now, carbohydrates in the colon can mean carbohydrate malabsorption, and this could potentially be due to intestinal permeability, because when there is intestinal permeability in the small intestine, there's less surface area for those carbohydrates to be absorbed, and we find them in the colon here. So this is a finding that is associated with the diagnosis of intestinal permeability. The inflammatory markers, lysozyme, calprotectin, lactoferrin, those are all within range. IgA is lower here for this patient. So IgA is 20.3. Now this could be low because the patient has an active infection and that they've utilized their IgA, or this could be low in a patient that has a low status of vitamin A, vitamin D, and zinc. And in this case, this actually is associated with vitamin D deficiency. So those two things go hand in hand. And quite often when you're monitoring your patient's vitamin D status, this is just another indication for that, right? Okay. The next piece of information we have here are the short chain fatty acids. Again, that short chain fatty acid balance is very important. So that's very important as well. And then we do see the elevated beta-glucuronidase, which we already discussed. And our last case here, this is a 13-year-old female who has history of multiple rounds of antibiotics. So the patient has a history of GI complaints, and her doctor, she was not unsatisfied with the history of antibiotic use because it does not seem to be resolving the symptoms. The patient has abdominal cramps, loose watery stools, and the antibiotics are not helping her. So let's see what happens with the GI360. Again, the first piece of information we have here with the GI360 is going to be that web. The web is a quick visual representation. And we can see here, this is not making a hexagon. The patient's lower in the actinobacteria, lower in the vermicroba, higher in those proteobacteria. So the proteobacteria are inflammatory. And so we think there's some inflammation here. Okay, the dysbiosis index score is 3. So we have moderate dysbiosis, and the diversity score is 2. So there's low diversity. So we want to support the different phyla here, and we want to get a little bit more information to find out what exactly is happening. So let's continue on the first page of the report and look at the key findings. Again, here we see the first column, the key findings organized by functional guilds. The first consideration is those butyrate producing bacteria. These are too low. So we want to support this patient because butyrate is anti-inflammatory in the colon. And that can be contributing to the finding of the pro-inflammatory bacteria. Those proteobacteria are too high. So we want to decrease inflammation for the patient, diet, or your own specific therapeutics. In addition to that, and we do want to support butyrate. So we want to support that with soluble fiber as well. And you can consider prebiotics as well. The gut barrier protective bacteria are influenced for this patient. And that's going to potentially lead to, like we saw in the last case, intestinal permeability. So we really do want to support butyrate to support the gut barrier protective bacteria. And then the pro-inflammatory bacteria are too high, which we know, we saw that on the web, and then that balance. So we do want to help this patient. The second piece of information we have here are going to be the additional key findings. The first finding we have is actually the Dientamoeba fragilis parasite. So this could actually be the consideration for the patient to treat complaint. Remember, the patient presented with abdominal pain, cramping, etc., loose watery stools. So you do want to treat this. Okay, and then the additional findings we see here are the short-chain fatty acid imbalances. So we see higher propionate, lower butyrate, and we do want to address that as we've discussed. Additionally, we see 2 species of cultured bacteria. So we have the Citrobacter and the Klebsiella. And these species actually can present with loose watery stools. So we do want to treat these as well. And then we see the Candida and the Geotrichum. So I'd be interested to find out the levels of these. So we can take a look at the culture page and see the value there. But it's a good thing that this patient did this report. And, you know, we're going to get some more information here. Okay. So of note, here is the Firmicutes page within the GI360. And we already know the patient's low in those functional guilds about the butyrate producers. And we can see that here on this page. So really significant, the Eubacterium hali, the Eubacterium rectali are low, the Fecalibacterium parnitzi, and the Lachnose brachii are low. Those are very key butyrate producers there. We really want to support these. We want to add soluble fiber. Of note, the Lachnose brachii actually likes cruciferous vegetables. So that would be a consideration here as well. Now, here we see the abundance and diversity results for the patient's proteobacteria, Tourniquetes, and vermicroba. So I just want to note here that the proteobacteria are too high. Remember, we have that balance here. And for this patient, the proteobacteria are high, the Enterobacterate and the Escherichia species, these are all high. These are associated with inflammation. Maybe the patient's eating excess dietary fats, excess proteins on the standard American diet. So these are all things to discuss with your patient. And then we do see that vermicroba is too low, that Akkermansia, right? Akkermansia is very in vogue these days, key contributor to mucosal barrier integrity. So we can see where that patient has that balance of the gut barrier protective bacteria are too low and those inflammatory bacteria are too high. So, you know, we can see this right here and we can help our patient. And here we have the parasitology result for this patient. This is the OMP. So this is the 3-day sample included in the GI360. This is the standard of care. And it's excellent information that we did find out for this patient. The dientamoeba has been found because that could be contributing to the patient's chief complaint. And then you can go ahead and treat this with iodoquinol, metronidazole treatment. Here we have the culture page for this result. Recall that the culture page is going to be dynamic for each patient. And so with this, it's going to be individualized. This is individualized medicine. It's going to look different for each patient that you have. Remember, the Aeromonas, 3 Yersinia, those pathogenic bacteria, we're always going to report the finding for those. And then the imbalance, the dysbiotic and yeast, again, this is individualized. So for this patient has a few species of imbalance, that's within normal limits, 2 species of dysbiotic bacteria, which we do want to address, and then the yeast. So the Candida is within normal limits, the geotrichum is too high. So you definitely want to treat the geotrichum, and you can or cannot treat the Candida, it depends. Okay. And here we have the sensitivities for the Citrobacter. And the great thing on doctor's data is that these sensitivities are not wall charts. This is the bacteria and yeast that was cultured from your patient's sample, put directly in vitro and reported. So this is clinically actionable results right here. And I just wanted to show that, when you do have multiple species of bacteria here, you want to find sensitivities that are in common. So for the natural agents here, we see uva ursi, grapefruit seed, and silver. So you'd want to pick maybe 1 or 2 of these. And then let's see what's going to be happening with the, and then we have the prescriptive agents, the septa, the cipro, the sulfa, okay? And then let's see what we have for the Klebsiella. So for natural agents, we're in luck because we have uva ursi, grapefruit seed, and silver. So those apply to both, okay? And then same thing with the prescriptive agents. So you do want to think when you have multiples, you want to consider those sensitivities. And again, very clinically actionable results. And in this case, the patient did feel much better after treatment. So thank you very much for your time today. I appreciate you taking the time to spend with us. And if you have any questions, we are always happy to assist. So please visit us at www.doctorsdata.com and also www.gi360.com. Thank you.